1, 2,
And review 70-year-old female
Oh shit, I almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's charter book.
300 please.
I'll keep your card again.
Pulse check. No pulse.
No more pulse.
Yeah. Where the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Imagine prepping like a standard everyday medication for your patient. You're at the bedside, getting everything ready. But if you happen to mix this specific liquid medication with just a splash of apple juice, it chemically neutralizes the entire drug.
Yeah, and even worse, if your hand slips and you accidentally spill a single drop of the solution on your own skin, you could break out in a really severe blistering case of contact dermatitis.
Right. So today, we are looking at a drug that acts, less like a simple therapeutic pill and much more like a volatile chemistry experiment.
It's the absolute definition of having to anticipate collateral damage, just to treat the primary target. You really have to respect the chemistry here, or it will absolutely backfire on you and your patient.
Welcome to this deep dive. Today, we have a very specific mission for you. We are stepping into the roles of your elite clinical pharmacists and expert nursing instructors to break down a notoriously complex pharmacology profile.
And we're applying the Pareto principle here, right? Finding that 20% of the core information that's going to give you like 80% of the clinical understanding you actually need.
Exactly. The understanding you need for nursing school, for safe bedside practice, and of course for conquering those incredibly tricky NCLEX-style exams.
Because, let's be honest, you cannot memorize a textbook. Knowledge is only valuable when you understand the underlying mechanisms and can actually apply them under pressure. We need to filter out the noise.
Right. Focus entirely on what keeps your patients safe.
Sure.
So the subject of our deep dive today is a medication called Perphenazine, which you will often see under the brand name Trilafon.
And we're going to put this drug through a rigorous 12-point clinical breakdown, tailored specifically for nursing safety and clinical judgment.
And I have to tell you, getting the details wrong on this one, it isn't just a missed point on a test. It is a real high-stakes problem on the floor.
Absolutely. What's essential here is that to truly master Perphenazine, you shouldn't just try to memorize like a random laundry list of side effects or mixing rules. You need to understand exactly why the drug behaves the way it does inside the human body.
Because if you understand the underlying mechanism, all those bizarre rules and honestly terrifying adverse effects will actually make perfect logical sense.
Exactly.
Okay, let's hit points 1 through 4. The identity, the target, and the action. We're talking about Perphenazine, brand name Trilafon. The sources classify this as a first-generation antipsychotic, but interestingly also as a phenothiazine antiemetic.
Right.
So we are prescribing this to treat severe psychosis, but also for, vomiting. How does one chemical do both of those things?
It's fascinating, really. To understand that dual action, we have to look at its primary mechanism of action. Perphenazine works mainly by blocking postsynaptic dopamine D2 receptors in the brain.
Okay.
It's essentially throwing up a massive roadblock to stop dopamine from binding.
So it just shuts down dopamine reception entirely.
Exactly. But it targets two very specific geographic regions in the brain. First, it blocks dopamine in a region called the mesolimbic system.
And that's the area tied to schizophrenia, right?
Yes. That's the area associated with the severe overactivity that causes hallucinations and delusions. By blocking dopamine there, it creates its expected action, the antipsychotic effect.
Got it.
But simultaneously, it also blocks dopamine in a completely different area called the chemoreceptor trigger zone.
And let me guess, the chemoreceptor trigger zone is like the vomit center of the brain.
Precisely. It's the area that detects toxins in the blood and triggers the urge to throw up. So block the dopamine receptors there, and you abruptly stop severe, intractable emesis.
Okay, but wait. If we are just flooding the brain with a chemical that throws up roadblocks on dopamine receptors, we can't possibly just hit those two specific areas, right? Aren't we accidentally hitting other systems in the crossfire?
We absolutely are, and that is exactly where the side effects originate. You can't isolate one single dopamine pathway perfectly with these older first-generation drugs. It is a shotgun approach, not a sniper rifle.
Like playing pharmacological whack-a-mole.
That's a perfect analogy. Furthermore, perphenazine doesn't just stop at dopamine, it also inadvertently blocks alpha-1 adrenergic receptors in the sympathetic nervous system.
Okay, so what happens when we block those alpha-1 receptors?
Well, when you block alpha-1 receptors, you prevent the blood vessels from constricting properly. This causes muscle relaxation and cardiovascular effects, specifically a sudden drop in blood pressure or hypotension.
Oh, wow. Okay.
On top of that, the drug also has moderate anticholinergic effects, meaning it blocks acetylcholine.
And anticholinergic always means drying things out, right? We're talking dry mouth, dry eyes, that sort of thing.
Right, so already, before we even look at a list of side effects, just by knowing this three-part mechanism, dopamine blockade, alpha-1 blockade, and anticholinergic action, you can predict with really high accuracy what is going to happen to your patient.
That makes so much sense. So based on that mechanism, point 4, the primary indications, the reasons we actually give this on the floor, are treating schizophrenia and treating severe, uncontrollable nausea and vomiting.
Yes, those are the main ones.
But the sources also note it's used off-label for severe behavioral or psychological symptoms of dementia, which we call BPSD, though I'm seeing some massive red flags attached to that off-label use.
Very massive red flags, which we will get into shortly. It is a highly controversial and tightly regulated application.
Let's follow that thread then, moving into section 2. Because knowing what the drug is supposed to do is only half the battle. To administer it safely, a nurse has to visualize exactly how the patient's body processes it.
Because that journey leads directly to its greatest clinical risks.
Exactly. So let's look at point 5, the pharmacokinetics, how the body absorbs, distributes, metabolizes, and excretes this chemical.
Okay, so when perphenazine is administered orally, it's rapidly absorbed from the GI tract. However, its overall bioavailability, meaning the amount of the drug that actually makes it into the systemic bloodstream to do its job, is surprisingly low.
How low?
It's actually only between 20 and 40%.
Wait, why is it so low? If they swallowed like a 10 milligram pill, shouldn't 10 milligrams make it into the blood?
You would think so, but it goes through extensive first-pass metabolism in the gastric mucosa and the liver.
Ah, so the liver intercepts it immediately.
Exactly. The liver aggressively metabolizes the drug before it ever reaches the broader circulatory system. It primarily uses a specific metabolic highway, an enzyme pathway called CYP2D6.
Okay, the famous CYP2D6.
Right. But here is a crucial clinical detail. As the liver breaks it down, it creates several byproducts or metabolites, and one of those metabolites, called 7-hydroxyperphenazine, is actually pharmacologically active.
Meaning, even after the liver has chewed it up and tried to break it down, the leftover pieces are still actively blocking dopamine and causing effects in the body.
Yes. The drug is still working, even in its metabolized state. And then we have to consider how it distributes through the body. It is highly protein-bound, somewhere between 91 and 99%.
Okay, stop right there. Because protein-bound is one of those textbook phrases that sounds really important, but often lacks context. What does that actually look like in the bloodstream?
Think of specific proteins in the blood, in this case, one called alpha-1 acid glycoprotein. Think of them like an exclusive shuttle bus circulating in the bloodstream.
Okay, shuttle buses.
When perphenazine enters the blood, 99% of it immediately boards these shuttle buses and locks itself into a seat. It is tightly bound to the protein.
Wow, 99%.
Yeah, only the tiny fraction of 1% that remains free or unbound is actually capable of leaving the bloodstream to cross the blood-brain barrier and cause an effect.
Okay, so the vast majority of the drug is just riding around on these protein shuttle buses. But it distributes widely into body tissues and has a half-life of 9 to 12 hours.
Right, and eventually about 70% of it is excreted by the kidneys.
But here is the massive clinical pearl for everyone listening, and it relates directly to those shuttle buses. Because this drug binds so tightly to proteins and distributes so deeply into the body tissues, the sources are incredibly clear. It cannot be removed by hemodialysis or peritoneal dialysis.
That is a critical safety parameter. Think about what that means in an emergency. If a patient accidentally overdoses or has a severe toxic reaction, you cannot just hook them up to a dialysis machine, filter their blood, and pull the drug out.
Because the drug isn't just floating freely in the blood. It's locked onto those proteins or hiding deep in the fat and muscle tissues.
Precisely. You can't dialyze it out. If toxicity occurs, you simply have to write it out, provide supportive care, and wait for the liver and kidneys to slowly process it over hours and days.
That is terrifying. honestly, and totally essential to know. And speaking of the liver processing it, that brings us to point 8, the major contraindications. Since the liver is doing all the heavy lifting, the sources state that perphenazine is completely contraindicated in patients with significant hepatic impairment. If the liver is failing, they just cannot take this drug.
Which makes perfect mechanical sense. If the liver's CYP2D6 highway is shut down, the drug isn't broken down, and it will rapidly build up to lethal toxic levels in the body.
But here is where I am completely lost, and where we hit point 11, the black box warning. The most severe safety alert a drug can have. Perphenazine carries a strict boxed warning regarding elderly patients with dementia-related psychosis.
Yes, it does.
Wait, you just told me a few minutes ago that this drug is used off-label specifically for our elderly patients with severe behavioral and psychological symptoms of dementia. But the black box warning says it's incredibly dangerous for that exact population.
I know, it sounds totally contradictory.
It really does. Why on earth would we give it to them?
It is a massive clinical paradox. The black box warning exists because geriatric patients with dementia are highly susceptible to the drug's collateral damage. They are incredibly sensitive to the orthostatic hypotension, which, causes catastrophic falls.
Right.
They're sensitive to the anticholinergic effects. But much more importantly, decades of clinical data show a significantly increased risk of death in this specific population when given antipsychotics.
Death from what specifically?
Typically from cardiovascular issues like heart failure, sudden cardiac death, or severe infections like pneumonia. Furthermore, there is a documented increase in cerebrovascular adverse events, meaning strokes and transient ischemic attacks, many of which are fatal.
That's awful.
It is. In fact, the Beers criteria, which is the definitive list of potentially inappropriate medications for older adults, explicitly says to avoid this drug in geriatrics with delirium, dementia, Parkinson's, or lower urinary tract issues.
Okay, so if the FDA slapped a black box on it, and the Beers criteria is flashing giant red stop signs, how is it still legally being used in long-term care facilities for dementia behaviors? It feels like medical malpractice.
Well, it comes down to desperate clinical reality and intense federal regulation. It is a treatment of absolute last resort. The Federal Omnibus Budget Reconciliation Act, or OBRA, dictates exactly how and when antipsychotics can be used in long-term care.
So you can't just hand it out freely.
No, absolutely not. You cannot just give this because a patient with dementia is being difficult or wandering or noisy. All non-pharmacological strategies like redirection or environmental changes must be thoroughly documented and exhausted first.
So it's only for extreme danger.
Yes. It can only be initiated if the patient is a substantial, immediate physical danger to themselves or others, or if they are suffering from severe distressing symptoms due to active psychosis or mania. And even then, the OBRA regulations cap the maximum dose at a tiny 8 milligrams per day for these patients.
And they can't just stay on it forever, right? Or they have to try to take them off it?
Correct. Facilities are legally mandated to attempt gradual dose reductions, or GDRs. They have to actively try to wean the patient off the medication in 2 separate quarters within the first year and annually after that.
Wow, they are really strict about it.
Extremely. The only exception is if the physician provides heavy, specific documentation proving that every time they lower the dose, the severe, dangerous target symptoms return.
Okay, that makes more sense. So the clinical red flag here is avoid in the elderly with dementia due to stroke and death risk, unless they are an absolute unmanageable danger. And even then, keep the dose tiny and keep trying to take them off it.
Exactly. It's a perfect example of weighing the immediate physical risk of the psychosis against the physiological risk of the drug.
Let's move into section 3, the collateral damage. Point 7, the side effects versus the adverse effects. Let's start with the mild to moderate side effects, which stemmed directly from those receptor blockades you explained earlier.
Right. Because of the anticholinergic effects, you will see xerostomia, which is severe dry mouth. You'll see constipation and urinary retention.
All the drawing out stuff.
Exactly. And because it blocks the alpha-1 receptors, you get drowsiness and that orthostatic hypotension we mentioned, that dizzy, lightheaded feeling when a patient stands up too fast because their blood vessels fail to constrict against gravity.
Annoying, and definitely a fall risk, but not necessarily lethal.
Yeah.
However, the severe adverse effects are a completely different story. These require immediate provider notification.
And again, to understand them, go back to the mechanism. We are causing an intense dopamine D2 blockade. Here is the paradox. Dopamine is absolutely essential in the brain for smooth, coordinated, purposeful muscle movement.
Right.
When you block it aggressively to stop a hallucination, you strip the brain of its ability to control movement. You induce what we call extrapyramidal symptoms, or EPS.
This is a huge critical concept for nursing exams and clinical practice. Let's pause here. We are essentially treating schizophrenia, which involves an excess of dopamine activity, by chemically inducing Parkinson's disease, which is a lack of dopamine. What does EPS actually look like when you walk into a patient's room?
It is unmistakable once you see it. You will see pseudoparkinsonism. The patient will have resting tremors, a shuffling gait, and severe muscle rigidity. You might see akathisia, which is an intense, agonizing internal restlessness.
Where they just can't sit still.
Exactly. The patient physically cannot stop moving or pacing the halls. They feel like they are jumping out of their own skin.
Now, what about dystonia? That one sounds terrifying.
Dystonic reactions are severe, involuntary, and painful muscle spasms, often locking up the muscles in the neck, face, or back. And if they are on the drug long-term, you risk tardive dyskinesia.
What does that look like?
It causes repetitive, involuntary movements of the tongue, lips, and face like lip smacking or grimacing. The tragedy of tardive dyskinesia is that it can become permanent even if you stop the medication.
That is a profound aha moment for me. By treating the mind, we are sacrificing the body's motor control. But EPS isn't the only heavy hitter. We also have to vigilantly watch for neuroleptic malignant syndrome, or NMS.
NMS is rare, but highly lethal. It is a toxic reaction characterized by extreme hyperthermia, a sudden, dangerously high fever, along with lead pipe muscle rigidity.
Wow. Lead pipe rigidity.
Yeah, and altered mental status and severe autonomic instability where their heart rate and blood pressure just fluctuate wildly. It is a medical emergency.
So EPS and NMS are your classic antipsychotic adverse effects. But Perphenazine have a few other terrifying tricks. It lowers the seizure threshold. It can cause rapid QT prolongation, which is a dangerous electrical arrhythmia in the heart that can lead to sudden death.
And it can cause a granulocytosis.
Right, which is a severe, life-threatening drop in white blood cells, leaving the patient totally defenseless against infection.
And we absolutely cannot forget SIADH syndrome of inappropriate antidiuretic hormone.
Yes. Explain the mechanism behind SIADH, because I know this is a major test trap on the NCLEX.
Okay, so SIADH means the body is inappropriately secreting antidiuretic hormone, forcing the kidneys to hold on to massive amounts of free water. When you retain all that excess water in the bloodstream, you heavily dilute the sodium levels. This leads to dilutional hyponatremia.
So their blood literally becomes watered down. Why is that legal?
Because of osmosis. If the sodium in the blood drops too low too fast, water rushes out of the bloodstream and into the body's cells to try and balance things out.
Oh.
Yeah. When water rushes into brain cells, they swell up like water balloons. This causes cerebral edema, brain swelling, and water intoxication. So if your patient on Perphenazine suddenly becomes confused or lethargic, it might not be their schizophrenia acting up. Their brain could literally be swelling from hyponatremia.
That is wild. Okay, let's look at point 6, drug interactions, because this connects right back to the liver.
Remember that CYP2D6 metabolic highway we talked about? Perphenazine isn't just a passenger on that highway. It is a potent inhibitor of CYP2D6.
Think of it like a massive traffic jam.
Exactly. Perphenazine clogs up the enzyme pathway. If a patient takes another medication that also needs that CYP2D6 highway to get broken down and cleared from the body, that second drug gets stuck in traffic. It remains in the bloodstream, builds up, and can easily reach toxic levels simply because Perphenazine shut down the exit route.
Okay, here is my absolute favorite part of the source material, the oral concentrate test trap. This is the stuff that clinical instructors and exam writers just love. Perphenazine comes in a concentrated oral liquid form, and it has to be diluted right before administration. But the rules for what you can and cannot mix it with are bizarrely specific.
It honestly reads like a very strange, restrictive cocktail recipe.
It really does. According to the sources, you are allowed to dilute this liquid with water, saline milk, 7-Up, carbonated orange beverage, or V8 juice. You can also use apricot, orange, pineapple, prune, or tomato juices. However, the no-go list is equally rigid. You absolutely cannot mix it with beverages containing caffeine, like coffee or cola. You cannot mix it with tannics, which means tea, and you cannot mix it with pectinates, which specifically singles out apple juice. Also, no mixing it with other liquid medications.
What's fascinating here is the underlying chemistry of why that rule exists. It's not arbitrary.
Yes. Why can I use apricot juice? But a splash of apple juice ruins the whole thing.
Well, the perphenazine molecule is chemically unstable when exposed to certain organic compounds. The pectinates found in apple juice and the tannic acid found in black tea will physically bind with the perphenazine in the cup.
So they literally lock onto it.
Yes. This chemical reaction essentially neutralizes the active drug, causing it to precipitate or fall out of the solution entirely. If you mix it with apple juice, the liquid in the cup is no longer therapeutic. You have completely ruined the dose before it even reaches the patient's lips.
Keep the apple juice out of the routine. Got it. Okay, knowing all these bizarre chemical rules and severe adverse effects, let's pivot to the practical reality. Section 4, the nurse's playbook. Point 9, interventions. What do you actually do with this information at the bedside?
For independent nursing interventions, we have to proactively monitor specific labs based on those heavy-hitting adverse effects. We need to monitor serum sodium levels closely when the drug is initiated and after any dose changes.
That's to catch that SIADH and hyponatremia risk early, right?
Exactly. We also need to monitor complete blood counts, or CBCs, to watch for leukopenia and that terrifying agranulocytosis risk.
What about safety on the physical floor?
Because of the intense drowsiness, dizziness, and orthostatic hypotension, falls are a massive immediate risk. We have to implement strict fall risk strategies, immediately bed alarms, assistance with standing, especially if we are dealing with a geriatric patient.
And there's one more administration safety rule that I hinted at in the intro, and it blew my mind. When handling that tricky oral concentrate we just talked about, the sources explicitly state the nurse must avoid spilling the solution on their own skin or clothing.
Because the raw chemical is so irritating, it can cause severe contact dermatitis.
You can literally give yourself a blistering skin rash just by prepping the medication.
It really highlights just how potent and reactive these older chemical structures are.
So how do we translate all of this into point 10, patient education? What are we teaching the patient who is being discharged home on a Trilafon prescription?
First, practical administration. They can take it with or without food, but if they experience gastrointestinal upset, they should take it with a meal. Second, what to avoid. They need to aggressively avoid the sun.
Because of photosensitivity.
Yes, perphenazine can cause extreme photosensitivity and even delayed hyperpigmentation of the skin. They also need to be taught the mechanics of orthostatic hypotension. They must stand up slowly, in stages, to avoid passing out.
And what are the emergency red flags they need to report immediately?
They must immediately report any signs of hyperthermia, like a sun high fever or severe muscle stiffness.
Because that could be the lethal onset of NMS.
Exactly. They also need to report any involuntary movements of their face, tongue, or limbs. That's the EPS, or tardive dyskinesia, starting. And they must report any signs of infection, even just a mild sore throat or low-grade fever.
Because that could indicate their white blood cell count has crashed from granulocytosis.
Correct. It's a lot to monitor.
It is a heavy, overwhelming list, which is exactly why we boil this down at the end. Let's move into our final section, point 12, your rapid-fire priority summary. This is designed strictly for memory retention and clinical safety. We are boiling down everything we just discussed into the absolute essentials. Ready?
Ready, let's do it.
Must know. Perphenazine is a first-generation antipsychotic and antiemetic that works by aggressively blocking dopamine. Because you are blocking dopamine, you must vigilantly watch for dopamine depletion emergencies, specifically extrapyramidal symptoms, or EPS, which was like Parkinson's and neuroleptic malignant syndrome, or NMS.
Nice to know. It is highly protein-bound, has an active metabolite called 7-hydroxyperphenazine, and is a potent inhibitor of the CYP2D6 liver enzyme highway, meaning it will cause a traffic jam and mess with the metabolism of other drugs.
Test trap. Mixing the oral concentrate. Remember, apple juice, coffee, and tea are absolutely forbidden because the pectinates and tannics chemically destroy the drug. Also, watch out for the tricky side effect of SIADH, which dilutes the blood and leads to dangerous brain-swelling hyponatremia.
Clinical red flag. The black box warning. Avoid in the elderly with dementia-related psychosis due to a significantly increased risk of death from heart failure and stroke. It is an absolute last resort under strict OBRA guidelines. And practically speaking, do not spill the liquid concentrate on your skin.
And finally, your one-sentence memory hook. Perphenazine halts the dopamine scene, but watch the elderly, the sodium, and keep the apple juice out of the routine.
That is a fantastic hook. That will definitely stick with you during a tough NCLEX question.
That's the goal. Thank you so much for joining us on this intensive, clinically focused deep dive into perphenazine. We have gone from the molecular lock and key in the brain all the way to the bedside realities of apple juice interactions and contact dermatitis.
If you step back and think about it, perphenazine perfectly demonstrates a profound truth about psychopharmacology. Treating the human mind is essentially a grand exercise in chemical compromise.
Yeah, that's a good way to put it.
We cure a terrifying hallucination, or we stop intractable vomiting by chemically inducing the symptoms of Parkinson's disease in the patient's brain. It really begs the question, as we continue to develop newer, more advanced generations of drugs, will we ever find a way to target just the symptom without disrupting the delicate, intricate balance of the entire nervous system?
It's a really sobering thought. We aren't just fixing a localized problem. We are shifting the chemical foundation of the whole house. Take this knowledge, respect the chemistry, and carry it straight to your exams in your clinical practice. You've got this.